Good evening, everyone. Thank you for coming to today's professional talk organized by Hong Kong Parkinson's Disease Foundation. Today, we have the great honor of inviting Professor Chaudhuri to talk on the practical approach to managing non-motor complications of Parkinson's disease. Professor Chaudhuri is Professor of Neurology Movement Disorders at King's College Hospitals and King's College London, and the Medical Director of Parkinson's Foundation International Centre of Excellence at King's College. He is currently Chairman of the Membership and Public Relations Committee of the Movement Disorder Society. He is also the co-editor-in-chief of Nature Group Nature Parkinson's Journal. He has written more than 400 scientific papers and co-editor of 5 books on Parkinson's disease and restless leg syndrome. Without further ado, let's welcome Professor Chaudhuri.
Hello there. Thank you, Mandy, for those kind words. And it's always a pleasure to be able to speak at Hong Kong, particularly Hong Kong Parkinson's Disease Foundation. I've spoken there before, and it's a shame that we can't travel. But thank you again for inviting me. I'm really pleased and honored, very much so. My remit today is really to talk to you about the management aspects of non-motor symptoms of Parkinson's. This is really quite a major task. And I'll try and cover as much as possible, although I admit that everything probably may not be possible. So I will start sharing my screen now. Mandy, I hope that's visible.
Yes.
Okay.
It's fine.
Thank you. Thank you. I'd start first by, as Dr. Young referred to, a lot of the work that I'll show in relation to treatment is based on our research work here at King's, which is spread between 3 sites, but mainly at the Denmark Hill site. Those of you who visit are very welcome to come one day at the King's College Hospital and the King's College Denmark Hill site. So I need to acknowledge all the colleagues and the Parkinson Foundation who support us with the Center of Excellence status. Non-motor symptoms, these are my disclosures. I just wanted for you to have a look at. So Parkinson's is a very interesting condition in the sense that it's only recently we've tried to understand what lies below the water. So what we see when people come to our clinic are the top of the iceberg. That we see the rigidity, we see the tremor, we see the gait and the postural imbalances, we see the akinesia, we see the bradykinesia, etc. But often what we don't see are the non-motor complex, which is the hidden part, and you can see that in this diagram. And I'm tasked with trying to cover the treatment of all of this, and that, as you will understand, is going to be very difficult indeed. So what I'm going to try is focus on some very specific non-motor aspects and see how we can manage those in clinical practice. Needless to say that it is the submerged or the hidden part of the iceberg, the non-motor problems, the sleep difficulties, the bladder problem, the pain, the depression, the anxiety, dementia, panic attacks, dysphagia, impulse control disorder, which is drug-induced, sexual dysfunction. All of this are the key drivers of quality of life in people with Parkinson's and their carers. So the treatment and management of the non-motor aspects of Parkinson's is really crucially important, particularly in modern treatment of Parkinson's. So where do we go from there? I think the important thing is if you address the non-motor problems properly, only then you can achieve what is now becoming a really good terminology for Parkinson's, the overall well-being. You can treat a person very well for tremor, for bradykinesia, or even dyskinesia. But if the patient has pain, if the patient is depressed, if the patient has huge anxiety, if the patient has sleep problems, gut problems, their well-being will not be there. So if you really want to affect the well-being concept, you need to treat motor and non-motor. So that's the message from here. And the other thing to remember, and this is from a review we did a few years back, non-motor issues in Parkinson's can affect all part of the body. So this idea that Parkinson's is only caused by the nigral damage in the midbrain, which we used to believe, is no longer true. It is a multi-system disorder. It affects virtually every part of the body, from the eye to the ears to the retina to the gut to the skin to the thermoregulatory organs, etc. So I think this is, and they express themselves largely as non-motor issues. And that is something that also one needs to be really conscious of, that you're talking about a multi-system disorder affecting virtually every part of the body. And another important point, sorry, excuse my voice cracking, I had a bit of a late night last night. The other issue that one needs to consider is really what the patients think. We must ask and talk to the patients. And if you see in this study, which is an old study now, 2010, it was published, and I was involved in this. This is from London, that we asked patients the top 10 bothersome symptoms that they have. And you can see out of the top 10, 7 are non motor, according to the patients. They're worried about their mood, their depression, dribbling of saliva, sleep, pain, bowel problems, urinary problems, and so on. Fluctuating response to medication, which I'll come across, can be both motor and non-motor. So that's motor fluctuations and non-motor fluctuation. As we know, tremor and falls are the two other things that bother the patients the most. So if we want to treat patients, we must also think about what are the symptoms that are most bothersome to them. And as you can see, non-motor issues play a major part. And this has been replicated many times now in other studies. We also have this other emerging concept that Parkinson is not just one disorder. We have written that it is actually a syndrome, and I strongly believe it is. It's a condition which is of multiple origin and with multiple neurotransmitter dysfunction presenting in various different sort of syndromic way. And it has, a recent suggestion has been that Parkinson can be divided into a cholinergic syndrome, a noradrenergic syndrome, a serotonergic syndrome, and then the mixed pattern. In each of these particular groups, there are some specific dominance of symptoms and therefore non-motor symptoms. And therefore, your treatment needs to be subtype specific to some extent and going away from the guideline concept of treating Parkinson's that one size fits all. So, this is another area that you really need to think about in terms of modern management of Parkinson's. We are still looking for more biomarkers for these areas, but so far, the progress has been fairly slow. The other areas is the treatment. When do we start? Now, this is a diagram of a journey of a person with Parkinson's. So you have the pre-prodromal stage marked by genetics and perhaps substantia nigra. Ultrasound imaging can pick up hyper echogenicity in the nigra. Then you have the prodromal stage when you get symptoms such as hyposmia, REM behavior disorder, constipation, depression, anxiety, visual, color vision loss. All of this are largely non-motor. And that's after that, the patient's coming to you for the diagnosis. So the person might have had the condition at least for 10 years. And then you have a stable period when you think, oh, wonderful, everything is great, patients are very well controlled, only for them to go into the unstable phase, then the advanced phase. We know the challenges there, which are both motor and non-motor, and then you come into a very specific palliative stage of Parkinson's. So if we divide the condition this way, you have to think about what treatment you can give in the prodromal stage, if you can diagnose the prodromal phase, and then stable, unstable, advanced, and palliative phase. And this is important because all of these phases are associated with a range of different non-motor aspects. Now, so let's look at what might be the unmet needs in relation to treatment. Now, one of them is neuroprotection. Neuroprotection is something that we don't have, and this is really addresses the de novo Parkinson's as they come to us first, or early Parkinson's, up to about 3 years maybe. Then you have the stable phase. Then you have the fluctuations, both motor and non-motor. Then you have the severe advanced stage when you have the issues about dementia and gait disorders mainly. And then you have all through this journey the issue about high burden of non-motor symptoms. And this you can grade using the non-motor scale. And if the score is over 40, you know that a person that you have in front of you has a high burden of non-motor symptoms, and that would need to be addressed. So that would be the first thing that one would need to think about when we are considering management of people with Parkinson's. So neuroprotection, and I bring this in because this has a non-motor angle, or neurorestoration is the concept that if you have a sort of a semi-linear progression of Parkinson's motor and cell loss, that we think happens. We're not 100% certain if it's linear or not, and if it's linear in everybody or not. We know progression patterns in Parkinson's can be very different. Neuroprotection or neuromodulation or neurorestoration aims to increase to make the line from here to perhaps in a more linear trajectory um, uh, around here, which would either make the condition stable or remain stable for a longer period of time, or delay the occurrence of certain motor and non-motor features at a later time. And that's the aim. And of course, this is absolutely crucial. If I develop Parkinson's, if I go to my doctor, the first thing I would like to know is, doctor, can you prevent me from getting dementia or severe depression or severe sleep problems, etc.? Or can you give me something that I remain as I am in 5 years' time? There will be no progression. But unfortunately, a neurorestoration is slightly different. Neurorestoration means you are trying to shift this line up. In this case, you are actually trying to prevent this trajectory going down, whereas neurorestoration is by replacing, say, for instance, a neurotrophic factor. You're trying to shift that line up. So both are trying to do the same, but in a slightly different way. Various strategies have been attempted, and here's a nice slide made by one of my fellows, Dr. Letta, Valentina Letta, and you can see that you can, if people have tried GLP-1, that's actually exenatide is a study that's happening very very soon here in the UK. Antioxidants, glutathione, iron chelators, lysosomal pathway, alpha-synuclein, targeted pathways, gene therapy, all of these have been tried, but unfortunately, none of them have worked. And here is a summary of the different ongoing targets. This is from my colleague, David DeVos from Lille. You can see that there are alpha-synuclein pathways, glucocerebrosidase pathway, GLP-1, iron chelators, gene therapy, all of these are in different phases of clinical trials. So where are we with this now? Well, I have to give you some bad news. In the last few weeks, we had Biogen, which has said no after the phase 2. This is a neuroprotection trial. Then came Sanofi, so their product, Venglustat, so they've dumped that. This was based on those with glucocerebrosidase mutation have increased accumulation of glucosylceramide in the brain, and it was trying to stop that, doesn't work. And then more recently, prasinezumab, which is the Roche product, have also failed in its primary outcome measure, although there are some potential signals which they want to explore in future trials. So it's been a really, really negative message, and there are many reasons for that. We don't have time to go into that, but suffice it to say, non-motor aspects dominate prodromal Parkinson's. At this moment in time, we do not have any neuroprotection or neuroprotective therapy evidence base that can work in this phase and perhaps address some of those non-motor issues. Okay, now let's come to some specific in-life manifest non-motor problems. The first one I picked up is depression. Depression is probably one of the commonest feature along with anxiety. We know from a range of, and I've just cited one, a seminal study by David Brooks in 2006, but also Philip Remy, who was then working with David on imaging using a dopamine and noradrenergic transporter binding ligands, showing that both depression and anxiety were linked specifically to the noradrenergic and the dopaminergic system, but there were some differences between the location of the depressive pathway versus the anxiety pathway. Now, this broadly can translate to clinical finding, suggesting that when you have somebody with severe depression or anxiety, you should perhaps be looking at dopaminergic and noradrenergic agents, moving away from the serotonergic agents that we often use. So they found that the catecholaminergic binding was higher in depressed versus non-depressed patients. This included the noradrenergic locus coeruleus, which is also cholinergic to some extent. The reduction was interestingly associated with severity of anxiety, but not depressive. So there again comes a little difference. If you have depression and anxiety, you treat one way. If you have pure depression, you treat one way. If you have pure anxiety, you treat another way, because the underlying pathophysiology seems to be a little bit different. And where do we come to that? Well, this is a nice study from Alistair Noyce, published in Annals a few years back, when they did a meta-analysis of different factors that might affect the onset of motor problems. In other words, the prodromal feature. And you see that one of the key aspects, there's mood disorders along with constipation. They come through quite strongly in terms of the odds ratio, providing an increased risk of Parkinson's. And of course, there are other things like pesticides, head injury, rural living. We beta blocker use, we sort of ask about those in our clinical practice. So depression, particularly, and anxiety can be a very marked prodromal feature as well. And more recently, this is work that we developed with my colleague Connie Maris in Canada, based on some fantastic piece of work from Richard Brown and David Byrne from here at King's College. I think Mike Samuel was part of that as well, yes, which was published in JNNP. They described a specific subtype within Parkinson's where there is a high emergence of depression and anxiety. And they divided the group into three groups: anxious depressed, which is probably the commonest variant, pure depression, which is not that common, and anxiety, which is very common. So more recently, when we have tried to do clinical endophenotyping of Parkinson's, and that's shown in this table, you can see that if you look at the neuropsychiatric subtype of Parkinson's, you can divide them up into three groups. There are some clinical markers. For instance, the anxious depressed group tend to be of younger age. They have more motor fluctuations. So fluctuations are associated with anxiety, whereas the pure depression group appears to have more older patients with a lot of postural instability and gait problems, etc. So I think there are ways you can separate them out. And how do you treat them? Well, unfortunately, although we have spent millions and millions in treating motor symptoms of Parkinson's, getting yet another trial, proper good quality evidence base for treatment of depression, anxiety is still sadly lacking. This is the evidence-based task force that Movement Disorder Society convened with Klaus Seppi, and I was part of that group, and with various other colleagues. This was published in 2019, and you can see here is a list of all the drugs that we could look at and look at their evidence base using this levels of evidence that is used in clinical practice. And you can see that the two drugs that come out as those for treating depressive symptoms are pramipexole, which has evidence base that it is something that we graded as efficacious, and venlafaxine. also graded as efficacious. Of course, there are other drugs as well where the evidence base is not that strong, rotating patch, rasagiline, as well as paroxetine amongst the tricyclics. The sertraline and citalopram, which we often use, do not actually have very strong evidence base. And you have to also remember the non-pharmacological interventions of repetitive transcranial magnetic stimulation, which is being used for depression management in many countries now, as well as cognitive behavioral therapy in severe major depressive episodes. They can all be useful, but there's a whole range of things. But if you want to bring it really strongly down, you've got pramipexole, you've got venlafaxine as your grade 1, and then you can think about some of the other drugs and other strategies that I've mentioned. Non-motor fluctuation is a massive issue in Parkinson's. I want to show you 2 videos. In one, the lady will describe the severe anxiety and pain that accompanies her off state, and in the other guy will talk about his mental clouding, brain fog. So, and these are the ones that's bothering their fluctuations, not the motor state. So let's watch and see what happens.
Down my side, my body's all twisted.
The body's twisted, and you're getting pain, is it?
Yes, I have pain down my back, and down here.
Okay, why don't you take the rest of the medication now? Do you feel quite tense and anxious?
Yes, I'm stiff. I can't, I'm just not kicked in at all.
Okay. That's it, very well done. You'll see it slowly will settle down now. So I give her some liquid levodopa, and that stops the off period, takes away her anxiety, takes away her pain. So here the treatment of anxiety and pain is not by giving anti-anxiety or analgesics, but treating the off period, for instance. And this gentleman. This is Mr. Owen Lampard. Mr. Lampard, you would say you're in off period at the moment,
yes.
Are you?
Yes, I am. Yeah.
And can you just describe the symptoms with the off period?
I have a feeling of tightness around my head.
Yes.
And all the scalp muscles contracting at one time.
Yep.
And it feels like a big weight on top of my head.
Okay.
And my neck is very stiff.
Okay. So it's a long video, so I won't go into the details, but the other gentleman's describing severe clouding of thought, tingling, and some pain in his limbs. And this is, again, off-related non-motor symptoms. So anxiety is a key part of that. What can we treat that with? As we saw in the imaging study, the management of anxiety is really based on either selective serotonin reuptake inhibitors or serotonin norepinephrine. So if you've got drugs like venlafaxine, like mirtazapine, like reboxetine, which is a specific noradrenergic agent, and also to some extent citalopram, can all be useful. Buspirone can be useful, benzodiazepines, with the caution that it affects balance and cognitive issues in elderly. And in severe cases, again, when the two converge, the depressive and anxiety cognitive behavioral therapy is probably appropriate. Moving on now, psychosis, as you will know, in majority of us who deal with Parkinson patients, when they go into acute stages of either infection or surgery, can end up with a psychosis. Important thing, particularly with COVID-19 floating around, is to distinguish between the delirium and psychosis angle. And that's really quite important. And one of the key things is the mental state. If the patient has, if the onset is acute, it's likely to be delirium. And if the patient has the mental state is clouded, or if they are confused, the chances are that you're really talking here about delirium. The management is therefore in the medical status needs to be addressed more acutely in the delirium. It's not that much of an issue with clear psychosis, for instance. And then what can we treat them with? But again, you can make a broad differentiation with minor psychosis. These are either passage, people floating by, illusions, you're seeing a cat, but it's not a cat, it's a leaf, like a cat, presence, somebody standing next to you, and finally diplopia, you can see double vision, but actually this is a hallucinatory diplopia, not an ocular diplopia. Then you can have hallucinations with insight, without insight, and delusions. When you have this, broadly, it's worth remembering that if you have people with minor illusions or even hallucination with insight, that can progress. So management is quite important, really. Clozapine is probably one of the best drugs we have. We have quite high restrictions for using it in the UK. Neurologists can't prescribe it. It's prescribed by psychiatrists, and one needs to be monitoring for aplastic or anemia or granulocytosis on a regular basis. But it is a very useful drug. Also helps tremor. But other drugs, the one that is used often is, in spite of quite contradictory evidence bases, quetiapine. In my personal experience, I find that quite useful actually. And so it'll be interesting to see your views. And then but the two drugs that really should not be used is olanzapine and also risperidone. These drugs have very severe dopamine blocking effect, and they can render a patient to a neuroleptic malignant state. So I think, please, it's very, very important not to use any of these drugs. And one thing to remember also in these group of patients, really to avoid anticholinergic drugs. And there is also the issue about the cognitive decline of the subjective cognitive decline. This is something that we haven't really properly addressed. It's work that one of our fellows here, Lucia Batsu, is undertaking now with some blood biomarkers and so on. This is a slide that was given to me by David Byrne, who's a big fan of the 60s seminal rock band called the King Crimson. And it's not, and you can see the band in 69 and then in 2017. And although the physical appearances have changed, their cognitive aspects remain pretty stable. So subjective cognitive decline is something that you see mostly in Parkinson's area. Again, something we don't know very well, but the mild cognitive impairment, if you find, can progress. And there's some very nice study on this. This is the campaign cohort from Cambridge. You see that 46% of these de novo patients who had mild cognitive impairment at onset, so these are patients who come to you for the first time, they will decline, and these patients will go on to develop dementia in 10 years. Others not. You can pick that up by doing a semantic fluency test and a Pentagon copying score. And this is a subtype. This is the cholinergic subtype. So in this particular group, it's really, really very important that we avoid anticholinergic drugs. That's the take-home message. In terms of treatment, this is again taken from the movement disorder. I've shown lots and lots of different imaging that you can do now with amyloid imaging, tau imaging, and of course dopamine transporter imaging, largely for dementia, donepezil and rivastigmine. Rivastigmine is the one there is the strongest evidence. Galantamine, memantine, all have been used to some extent. The non-dementia cognitive impairment, in other words, the MCI group, again, rivastigmine, but probably there is some emerging evidence of rasagiline also being partly useful. But here, if you do have the access, TDCS, which is transcranial direct current stimulation, as well as cognitive behavioral therapy, have all had some element of work done on it. But as you will see, the evidence base really remains fairly poor. So another area of big challenge for us. Apathy. Apathy is a problem that might coexist with these conditions, with depression and with anxiety and with dementia. You have a reduced motivation to day-to-day activity, you have a reduced interest in talking to people, you have a reduced experience in experiencing emotions. Now that blends in with this other condition called alexithymia. This could be dopaminergic or non-dopaminergic. This could be comorbid with depression. It could be comorbid with somnolence. It's a very, very challenging area. How do you differentiate all of these things out? But it's worth remembering that apathy and alexithymia are actually very common in Parkinson's as well, particularly in the cholinergic subtype. And people, this is work from Jaime Kulisevsky's group in Barcelona, showing that the neural networks that have the different types of apathy, the emotional apathy, the cognitive apathy, and the autoactivation apathy. This is apathy that just is there as an internal expression of the Parkinson's, are mediated mainly through the cholinergic and the dopaminergic circuits, the two main circuits that are active. And if you think about treatment, and this is one of my ex-fellows, Anna, looking fairly apathetic after she's had a meeting out with me. Here you see the interventions to treat apathy, very poor evidence base. This is taken again from the MDS Task Force review. Dopamine agonists are actually quite good for apathy. The evidence base is there for retigaine and Pergidol. Those who have it, we don't have it in the UK, but rivastigmine also. And I do think rivastigmine has a very strong effect in apathy because you can see people's face light up. You can see their mood get better. So rivastigmine should not be forgotten when you're looking at the possible management of apathy. And there is some evidence, this is again work from the Barcelona group, suggesting that if you looked at the dopaminergic drug, and this is a study, a cross-sectional study, but prospective, non-demented PD patients with apathy. And here you see that the effect is the best with pramipexole, not surprising, given that it has a very strong antidepressant action. Ropinirole, not as good, but better. And levodopa, again, can work, but not as good. So if you are really focusing on the apathy angle, again, pramipexole and retigaine patch might be two drugs where at least the evidence base seems to support their use. Fatigue is another very, very important issue that you need to think about. There are two types of fatigue that you can clinically determine. One is a fatigue that you feel, which is disproportionate to the exercise that you've done. And the second one is exhaustion that for a defined period that is unexplained by the drugs or the medical condition or psychiatric disorders. So it's, again, comorbid with lots and lots of different other neuropsychiatric issues that we've already discussed. It's worth remembering that fatigue can be present in de novo Parkinson's. So your early de novo Parkinson, fatigue could be prodromal. And there's some evidence biomarker-wise that if you look at de novo Parkinson's, this nice work from Italy, from Tessitore and his group, showing that you find decreased connectivity in the supplementary motor area, whereas increased in the prefrontal and posterior cingulate areas. So there's an imbalance that's already happening in the de novo state of Parkinson's. There is also evidence from PET studies. This is again another seminal piece of work by David Brooks, showing that you appear to have a very specific deficiency of the serotonergic binding in the limbic area of the striatum in fatigue Parkinson, but not in non-fatigue Parkinson. And this would lead to the concept that if you do find this, you could do a subtype specific treatment with serotonergic drugs for fatigue. This work is still continuing. We don't have very good trials yet to support this hypothesis. And it's also worth remembering that fatigue is comorbid with motor EPDRS, but not fluctuations. It is comorbid with anxiety, depression. It can be comorbid. If you have a patient with significant fatigue, it's very likely that their non-motor burden will be very high. It's comorbid with sleep dysfunction, particularly insomnia. And finally, frontal lobe issues, as you would see in that connectivity abnormality that I just showed you. So you have to take all of these into account as well when you're trying to manage the issue about fatigue. And what treatments do we have? Well, this is a very nice meta-analysis of all the different drugs used for fatigue, and what emerges that there is a weak evidence base for rasagiline, both at 1 and 2 milligram doses. Methylphenidate, which is used as a stimulant, can also have a weak evidence, but modafinil by far has probably got a much stronger evidence for management of fatigue in Parkinson's. And I would recommend that, and you do need to use to quite reasonable doses to get the effect on fatigue. With another drug, which I have very little experience of, is doxepin. which also has a strong signal and graded exercise. And this is again really important that all management of these non-motor aspects, not just pharmacological, there's evidence from acupuncture, exercise, cognitive behavioral therapy, TMS, all of these can be effective for some of these. And fatigue is another area where dopamine agonists might be particularly beneficial. And this is why we have said that there is an agonist phobia going around, because some of our key opinion leaders have been going around telling agonists are terrible, don't use them. But actually it does some harm, because agonists also have some beneficial effect on the non-motor aspects. And this is another example where this is a very nice study from the ParkWest, the Norwegian cohort study, which has been going for many years with Guido Alves and others, and Jean-Pierre Larsen, and JP Larsen and Doug Arslan and others. And these are drug-naive Parkinson patients who have been being followed up as part of the ParkWest project. And you can see that those who were on dopamine agonists at baseline, they did better in relation to their fatigue at 1 year than those who were not. So indirect evidence that agonists might be actually quite useful, again, in the management of fatigue as well, apart from the drugs that I've shown you. And there is further evidence. This is the RECOVER study, where retigatin was compared with placebo, for instance, and you have scales where fatigue was measured, and you can see clearly a difference between the mean change from baseline score with the retigatin patch and placebo in terms of improvement of fatigue. So there is actually indirect level 1B evidence to support the use of agonists, in this case, retigatin patch for management of fatigue. Broadly, therefore, how would you summarize management of fatigue in clinical practice practically? The drug that we have not mentioned, and I use quite a lot, is amantadine, 100 to 400 milligrams, but modafinil probably the best drug, but you have to go up to 200, sometimes even higher. Rasagiline 1 to 2 milligram. You could take recourse in agonists, particularly retigatin, and high-dose levodopa. So levodopa infusion therapy, for instance, works very well for fatigue in many patients, but clearly an area where a lot of work needs to be done. Okay, I'll sort of skim through because I'm conscious of the time. We have interventions to treat fatigue here. This is from the evidence-based review. As you will expect, there is very little. I've already mentioned rasagiline, ethylphenidate, modafinil have all been mentioned. But the other one that also you should consider is acupuncture, because along with pain, this is another area where acupuncture does have some reasonable evidence base, although this particular trial from Benzi Kluger's group in the US was actually negative, but they did show the patient's self-reported fatigue were improved after a 6 weeks course. And this work from Singapore, from Louis Stan and other colleagues, where I was actually positive. So it's an option that you can think about in relation to management of fatigue in Parkinson's. Okay, another area is exercise. Exercise now is emerging as a very strong treatment paradigm for various neurocognitive areas of non-motor aspects. Fatigue is another example where in this particular randomized controlled study, small study, but nevertheless controlled, there was a clear evidence of resistance training, an 8 weeks resistance training program based on the lower limbs. And they use some scales as well, showing that the dynamic balance that the fatigue had particularly improvement, and also their perceived fatigue. So this is an area, and I'll touch upon that at the end of the talk. I'll move to pain now. Pain is a real issue in Parkinson's. Often not asked about people because there are comorbid pain as well. You can have rheumatic pain, you can have joint pain, but pain is such a problem, and there's been so much written about it, and a lot of it we described the first scale for Parkinson's, for pain, King's Parkinson Pain Scale, the questionnaire, and there's a big, pain is another really complex area where we have so many multi-neuropeptide involvements. and different subtypes. This is a subtype that we described, the unexplained lower limb pain syndrome. Patients usually present with a burning discomfort in the upper part of the thighs and the pelvic areas. You do scans and so on, everything is negative. And this is actually a manifestation of central pain, usually seen in males, often not fluctuating and often responding here, strangely, to opiates. Um, and I will, this is like a little summary made by Rukavina Katerina, who's our pain fellow. And you can see that on one side, you have the dopaminergic pathway involvement. So that's more the fluctuation related pain. So here, the best thing is to try and address using drugs with continuous delivery, retigotine, apomorphine infusion, COMT inhibitors, even safinamide, which has this dual action through the monoamine oxidase and the glutamate pathways. You have the serotonergic pathway involvement as well, and that is why drugs and noradrenergic drugs which are used for anxiety, venlafaxine, duloxetine can be have been tried. Clearly, involvement of the opiate system is cardinal. So Targinac or oxycodone, naloxone, then tramadol have all been used for pain relief generally, but same for Parkinson's. The glutamatergic pathway is also involved, so gabapentin and pregabalin comes in there, as does safinamide. And finally, more recently, there's been some interest in the cannabinoid system, and there's at least one trial looking at cannabinoids, looking at whether, along with cognitive aspects, it can help pain in Parkinson's. And finally, non-pharmacological approaches are many, physical activity, focused physiotherapy, acupuncture, etc., and electrodes. And I'll show you some data on the trials in progress. I think it's really, really important, therefore, to not clump pain together, but at least use the questionnaire or the scale to classify the type of pain your patient's having and then address the symptoms, because how you treat fluctuation-related pain, like I showed you in the video, is going to be very different to how you treat central pain syndromes in Parkinson's. So it's a very complex area indeed. And these are some of the trials that are currently ongoing. You can see there is the oxycodone trial called Oxydopa, botulinum toxin for foot dystonia. We're due to start a trial called Ocean, where we're going to look at the effect of opicapone, COMT inhibitor, on how that can address motor fluctuations and pain. And there are other things such as transspinal magnetic stimulation, mental representation techniques, using mental wellness aspects, reflexology, Pilates, all of this are being tried. So it's good to see there is activity, so much activity going on in the pain area of Parkinson, including hypnosis, which is, I won't have time to talk about it, but there is some really, really strong amount of work going on that from Austria, for instance, looking at the hypnosis and pain control in Parkinson's. In terms of what the evidence base we have, very limited. Only 2 drugs cited in the MDS task force document. As you can see, retigotine, which has some evidence, level 1B, based on the recovery, but where that was not a primary outcome measure. And more recently, the PANDA study showed efficacy of oxycodone and naloxone combination at 12 weeks, but not at 16 weeks. But both, therefore, insufficient evidence, but they are the only 2 drugs that can be actually named. But of course, there's a whole range of others that we've already touched upon. So in terms of how you manage it, it's really, really depends on the etiology and the type of pain. Musculoskeletal pain can be part of Parkinson's, and you then have to think about also pain that can be associated with postural deformities, particularly those with camptochromia and Pisa syndrome. And in some of these cases also, you might have to, along with physical exercise and physical therapy, you might have to also try use baclofen and botulinum toxin in focused areas to see if you can assist and help with some of the postural changes. And acupuncture, as I said, seems to have a reasonable effect. This is work actually we did with our Taiwan colleagues, showing that with acupuncture, you do activate some of the central pathways that we know are active in pain by doing fMR connectivity studies. And on the whole, there was a 46% reduction in the Parkinson's pain score. So it's something definitely worth thinking about in unexplained or severe pain syndromes in Parkinson's disease. I want to end with sleep and some of the drug-related effects. Sleep is a particular problem. I don't really have time to go into the details of sleep management in Parkinson's, but sleep events like shown here, sudden onset of sleep, can be actually disturbing for patients. It can resemble narcolepsy. Some patients might fall and cut open their head, as you see. How do you manage all these different sleep problems? Well, the first one I'm taking on is the sudden onset of sleep. Why? Because if you're not careful about it, your patients might fall asleep and kill themselves and kill other people. And this is largely a drug-related issue. As you will remember, the very famous paper in 1999 from Stephen Frucht from Stan Farnes' group, falling asleep at the wheel, motor vehicle mishaps in patients taking pramipexole and ropinirole. They do activate the D3 system, which brings on this sudden onset of sleep. So this is something you need to be really careful about in susceptible people, which we think is now the serotonergic subtype of Parkinson. What are the drugs that could be recommended? Poor Anna, another picture of her falling asleep there. It's basically not a lot you can have. If you have insomnia, which is of sleep onset insomnia, then there is a range of dopaminergic drugs you can try to help the patient's motor state, which indirectly will help them fall asleep. But and always remember sleep apnea, which can occur in about 20% of patients, causes severe daytime sleepiness and can be completely treated with continuous CPAP or by the assisted breathing apparatus that is now available. But in addition, there is excessive daytime somnolence where modafinil, high-dose caffeine, and CPAP, if there is sleep apnea, might be really, really quite effective. One area is REM behavior disorder, and you're all familiar with it when people can act out violent dreams. REM behavior disorders need treatment when they are either physically intrusive to the partner or the patient sustaining injuries themselves, falling out of bed, hurting themselves. So physical RBD clearly needs treatment. Melatonin probably is one of the best treatments available without the side effects of clonazepam, but very important to remember that melatonin works, but you need to use quite high doses, up to 12 milligrams. And my sleep colleagues tell me up to 14 milligrams. And if you use the longer acting version, up to 6 milligram, the RBD behavior after 6 milligram is better than what you get with clonazepam. So less side effects particularly, and it reduces the behaviors and injuries. And there is also evidence that if you use the longer acting melatonin, the circadian, this is a nice study from Simon Lewis in Australia, showing that up to 4 milligram, it doesn't really work. So it needs to really go up on doses, and you need to monitor that with the patient's health status. So usually, therefore, combination of circadian and clonazepam are the mainstays of treatment. There is some literature here showing that pramipexole can also be effective. I don't know the pathophysiological basis of that, but certainly there's a range of case reports suggesting this. My personal experience of this has not been particularly useful, but pramipexole can be a drug that you can also think about in relation to RBD. Lastly, autonomic dysfunction, another huge area. For orthostatic hypotension, we have the standard paradigm: drink enough water, at least 2 liters a day, fludrocortisone, midodrine, which is a peripheral vasoconstrictor agent. Domperidone can be useful, but you have to remember the cardiac side effects. And more recently, in some countries, you have droxidopa or L-DOPS that's been licensed. So these are the standard sort of therapies. Not a lot of work has gone around with sexual dysfunction, apart from using Oxalis and Viagra, but with their own side effects. Constipation is an angle that we will touch upon. As you can see, the drugs, apart from fluid intake, macrogol is probably the drug that's most widely used, but lubiprostone has also been thought to be likely efficacious. And there are one or two other drugs which are working on the gut peptides that are also being tried. And urinary dysfunction and drooling of saliva are such massive problems. Chewing gum or ice in the mouth, ipratropium or atropine spray, glycopyrrolate in some. Usually they're not very useful, but botulinum toxin, particularly type B, into the parotids and submandibular glands is probably the best treatment that we use for drooling. And for urinary dysfunction, either solifenacin or finasteride, depending on the prostatic pathology, are the sort of drugs that you will probably want to use. Constipation is a massive issue in Parkinson's. This is taken from Annette Schrag's work, showing that people who have constipation in your right might have the constipation for many years before the condition is even diagnosed. It's a prodromal feature, and there is growing a recognition that constipation could be related to our gut microbiota being abnormal with overexpression of the toxic microbiotas which do not protect our gut microbes, and suppression of the good microbiota which actually protects the gut from alpha-synuclein being degraded and being deposited and probably being carried by the vagus nerve to the brain. So huge implications. And there is evidence that either fecal microbiota transplantation can or probiotic use might be useful. Why? Because they will replace the microbiota to the healthy amount and then perhaps reverse some of this problem. There are many issues with fecal transplantation, transfer of viral disorders, ethics, etc., etc. So probiotic use, which can penetrate your large bowel, is actually an attractive option. We are actually carrying out a trial now. This is Valentina Letter's work, where Simprove, which is one of the few probiotics which can actually penetrate your large bowel and don't get destroyed in the stomach, is being used to show whether or not A, it helps constipation, and B, it improves the overall non-motor well-being, the well-being of patients through the vagus pathway. Whether or not this will work, we don't know. But so I do advise probiotic use in people with Parkinson's, particularly who have a high sort of non-motor burden. It's something worth thinking about. Impulse control disorder, I would spend very little time on. It is something that is ubiquitous. It's there amongst virtually all of us, but it's manifest more amongst the Parkinson's patients on dopaminergic drugs because of the reward cycle activation. And again, the treatment base is really, really very poor. Often you need to address the neuropsychiatric element. There is at least one study showing a very weak effect with naltrexone, non-pharmacological intervention, and clearly reduction of the oral dopamine agonist intake is very useful, but worth remembering that once people are on these dopamine agonists, it's actually very difficult to take them off this dopamine agonist because of the dopamine agonist withdrawal syndrome. So very often you might have to keep a small dose of dopamine agonist going along with the treatment strategy that you're undertaking. Two new drugs to talk about. Safinamide, I've already mentioned, might have quite considerable non-motor activity, particularly pain and cognition. This is being currently looked at because of its glutamate action. And the other one is opicapone. Opicapone is a COMT inhibitor, which is being looked at again for pain and sleep. So we need to see what this data will tell us about these drugs in future. Anything else? Well, what about the advanced therapies? We have DBS, we have apomorphine, we have levodopa infusion, and the latest is Lesigon, which is levodopa with entacapone combined in a very small pump. As you can see, this pump is smaller than the apomorphine pump. Whether or not these drugs will have a specific non-motor effect is investigational, but we already have some signal from the EuroNF2 study, which we conducted and published a few years back, showing that if you compare DBS, levodopa infusion, apomorphine, they all have non-motor effects, beneficial effects, some detrimental effect at 6 months follow-up, but you can differentiate them. but the scope of that is beyond this talk. So it's worth remembering that there would be non-motor effects on that. So I think I would probably like to stop there because I had a few more slides about the new drugs. There's quite a few. This is exercise. Let's stop there. And finally, COVID-19. COVID-19, this has been recently published showing that this might have major non-motor effect in people with Parkinson's. And it's really, really worth remembering the effect, particularly on ageusia, taste, anxiety, fatigue, and pain, and in the long term, possibly cognition. So to end, motor versus non-motor Parkinson's, I think it's really important that you personalize your treatment as best as you can, depending on the non-motor symptoms and the subtypes of Parkinson's. So the evidence base is really just emerging. The focus is really developing new treatment for dyskinesias, but we mustn't forget that treatment and management for non-motor symptoms still remains a massive unmet need. And this is a plea to all researchers, please do think about researching and developing treatments for non-motor symptoms of Parkinson's. These are some of the guys who have helped us with some of the talks from my group, and I thank all the guys working in our group. Thank you, Mandy. I'm sorry I went over time. Too much to cover.
Thank you, Professor, for the excellent, comprehensive lecture on non-motor symptoms of Parkinson's disease. Now we come to the Q&A section, and we have one question from Parkinson's disease patients over 10 years of disease diagnosis. And he's asking that he's been taking fruit, veggie, and then white meat and yogurt, and exercising vigorously, 5,000 steps of walking per day, and keeping active with housework, bowling 5 to 6 times a week, and sleeping 8 hours per night. And he's been trying to keep his emotion calm. And his question is any further modifications that can help him to keep his PD control even better. Sorry, no sound.
Yeah, I think the gentleman is doing everything that is good. Lifestyle is such an important aspect of non-motor management, particularly depression and pain and anxiety and sleep, and cognition perhaps. So yes, I think probiotics, exercise, but the exercise needs to be graded. In other words, not over-exercise because that can cause fatigue. And also the mental and physical well-being exercises, they're all fine. And I think that's on the right track.
That's great. In the interest of time, we have to close this talk. And thank you everyone for coming. And thank you, Professor, for the excellent talk. Thank you. I hope we can see each other soon in Hong Kong.
Yeah, I'm looking forward to. I mean, I've not been to Hong Kong for 2 years. Seems like too much.
Yes, you are our old friends. We look really forward to that. I hope it will be really soon.
I would love to. Yeah, hopefully COVID goes away soon. Thank you.
Thank you. Thank you.
Thanks.
Thank you, everyone.
Okay.
Okay. Okay, happy Easter, Professor.
Sorry, I forgot. Yes, of course. Happy Easter. It starts tomorrow, doesn't it?
Yes. Okay, see you.
Thank you.
Okay, thank you. Bye-bye.